What if I told you that the very place you go for safety, for reassurance, for healing, could be triggering a physiological reaction that falsely labels you as sick, leading to a cascade of unnecessary, dangerous, and life-altering medications? That your body's primal fear response in a clinical setting is quietly writing a prescription for side effects you never needed to endure, setting you on a path towards frailty, falls, and a loss of independence that began not with a disease, but with a misinterpreted number. Brand new research from the last 18 months reveals that the common dismissal of white coat syndrome is a catastrophic medical oversight. It's not just nerves. It's a diagnostic red flag waving frantically, and when ignored or mistreated, it leads directly to the very outcomes we fear most. I'm about to show you the stark, life-altering difference between a harmless spike and a hidden lethal condition that looks identical under the fluorescent lights of your doctor's exam room. The wrong interpretation doesn't just mean extra pills. It can mean the difference between living vibrantly in your own home and a devastating decline that started with a simple misread moment of stress. I'm Dr. Alan Whitman, a geriatrician with over 2 decades of experience dedicated exclusively to the health of seniors. I've sat across from thousands of patients just like you, individuals who were convinced they had a dangerous, progressive heart condition because of a number read in a sterile, anxiety-provoking room. After untangling this web for 22 years and reviewing countless medication lists filled with drugs begotten from these moments of panic, I can tell you with absolute certainty, the standard medical response to this phenomenon is not just incomplete, it's actively, systemically harming the senior population. We are creating patients out of perfectly healthy people and then making them sick with the cure. By the end of this critical video, you will know with clarity the 2 specific, biologically distinct types of blood pressure reactions that happen only in the clinical setting, and you will be able to identify which one you have. More importantly, you'll learn which one is a silent emergency masquerading as simple anxiety. You'll master the 5-step true pressure protocol I use in my clinic to bypass the panic and diagnose the real, living truth of your cardiovascular health. And I'll give you the exact, scripted words to say to your doctor, words that will change the trajectory of your care, potentially saving you from a future of dizziness, falls, and unnecessary chemical burden. But I'm not going to tell you those words yet. I'm going to withhold them deliberately, because if you walk into that exam room unprepared, armed only with a feeling of being unheard, you'll be dismissed with a pat on the hand, a reassuring smile, and a prescription for a medication you may not need, a prescription that could alter the course of your life. You need the full story first. You need the why that fuels your conviction. First, I need to see the scale of this. I need to understand who is watching and what you're experiencing. In the comments below, I want you to type your last clinic blood pressure reading and your age. Then, if you have one, type your home reading from around the same time. Be honest. Format it like this. Clinic, 162/94. Home, 138, 80 seconds, age 74. Or clinic only, 155/88, age 68. If you've never taken it at home, just say that. This raw collective data is the heart of the crisis I see every single day. Now, let me tell you about Harold. His story is the perfect tragic archetype of a system that has been trained to treat a number instead of a human being. A system that values the data point over the data's context. Harold was 77, a meticulous retired accountant who had spent his career finding truth in columns of numbers. He valued precision, order, and verified data. He had mild, well-controlled hypertension for about a decade, Managed with a low-dose diuretic, he lived independently, tended a prize-winning rose garden, and enjoyed weekly chess matches at the community center, where his strategic mind was still formidable. Then, during a routine physical, everything began to unravel. The nurse, cheerful and efficient, wrapped the cuff around his arm. He felt the familiar squeeze, the gradual pressure. He watched, almost hypnotized, as the digital numbers on the wall-mounted monitor began their ascent. 140, 155, 168. The diastolic climbed to 96. A silent alarm bell clanged in his own chest. His doctor entered, scanned the vital signs sheet, and his brow furrowed. "Harold," he said, his tone shifting from friendly to concerned, "this is too high. This isn't where we want to be. We need to be more aggressive with your control." This was the beginning of the false security phase, a period of escalating intervention based on a flawed premise. The doctor, following the standard algorithmic protocol for a persistent high reading, increased Harold's low-dose diuretic and added a second medication, a calcium channel blocker. The goal was clear and seemingly rational: get that clinic number under 140/90ths. Harold, trusting of authority and compliant by nature, a man who believed in following the rules, did exactly as told. He took the new pills diligently. At his 1-month follow-up, his clinic reading was better, 142/88ths. "Progress," the doctor said with a satisfied nod. Harold was given the all-clear. He was now officially controlled. The system had registered a win. But at home, Harold was a different man. Unbeknownst to his doctor, Harold, the data enthusiast, had purchased a well-reviewed home blood pressure monitor. Following the instructions meticulously, he began taking his pressure twice daily, once in the morning before his medication, once in the evening before dinner. He kept a leather-bound logbook. His living room readings, taken in his favorite worn armchair after 5 minutes of quiet breathing, told a profoundly different story. 118/76ths, 122/78ths, 115/74ths, 120/80ths. Textbook perfect. Normal. He felt a quiet pride in these numbers, evidence of his good health. At his next quarterly visit, he presented his logbook to his doctor, expecting praise for his diligence. The doctor took the book, glanced at the neat columns, and then took Harold's pressure in the office using the same wall unit. The result, 158/90. The doctor handed the logbook back. "Harold," he said not unkindly, "these home monitors are often inaccurate. They're not calibrated like our equipment here. You can't always trust them. We have to treat based on what we see in the office, where we know the measurement is correct. That number today tells me we need to increase your dose again. That home reading is probably giving you false reassurance." The warning signs ignored emerged within weeks of this second dosage increase. Harold started feeling a pervasive lightheadedness, especially when he transitioned from sitting to standing, a phenomenon called orthostatic hypotension. A deep, unshakable fatigue settled in, a heavy weariness that his afternoon tea couldn't shake. One Saturday afternoon, while watering his beloved roses, he bent down to adjust a soaker hose and stood up too quickly. The world tilted, then spun violently. He reached instinctively for the wooden garden fence, but his coordination was off, his muscles responding slowly. He fell, landing hard on the stone path, his outstretched wrist absorbing the impact with a sickening crack. The diagnosis in the ER was a fractured distal radius. His blood pressure upon admission? 112/68ths. The ER doctor, reviewing his medication list, noted, "Mr. Jenkins, You're on a fairly robust dose of blood pressure medication. You might be a bit over-medicated. Make sure to follow up with your primary about this." But his primary care doctor, when informed of the fall, attributed it to bad luck and maybe a touch of vertigo from an inner ear issue. The sanctity of the clinic reading remained the gospel. Harold's home logbook, now showing consistent readings, dipping between 105/70ths and 110/72nds. Readings that are dangerously low for a 77-year-old, and a direct cause of dizziness, was dismissed as evidence of faulty technique. The system had chosen its data point, the one generated within its own walls, the one that justified the ongoing treatment. The patient's reality was relegated to the status of a technical error. The crisis event happened not in his garden, but in a place of presumed safety, his local pharmacy. Harold was waiting in line to pick up his refills. The very medications chasing the phantom high number. He'd been feeling woozy all morning. As he stood, he felt the now familiar yet suddenly overwhelming wave of dizziness, a black tunnel closing in on his vision. He blacked out completely. His body went limp, and he collapsed straight back, his head striking the hard, unyielding tile floor with a horrific thud. The sound brought the pharmacist running. Concussion, subdural hematoma, a bleed on the brain, another ambulance ride, this time with lights and sirens, back to the same hospital. The cascade was swift, brutal. The brain bleed required urgent neurological observation and forced immobility. Confined to a hospital bed, he developed a urinary tract infection from the catheter. The infection, combined with the metabolic stress of the brain injury, spiraled into a vicious, hospital-associated delirium. The sharp, precise accountant, the man who could recall chess moves from 3 weeks prior, became confused, agitated, and paranoid. He was placed on antipsychotic medications to calm him, which further sedated him and increased his fall risk. His muscles, unused and metabolically hampered, atrophied. A physical therapist, in a valiant but desperate attempt to prevent pneumonia, tried to get him walking. Weak, dizzy, and cognitively fogged, Harold's legs buckled. He fell again, right there in the hospital room. This time, it was his hip. The femoral neck fractured. The surgery to repair the hip was technically successful, but Harold's spirit and cognitive reserve were broken. The cascade of iatrogenic harm caused by medical treatment itself, was complete. He never fully recovered his cognitive sharpness. The independence he cherished, the roses, the chess games, were gone. He transitioned to a long-term care facility. The last blood pressure reading entered into his chart at that facility, taken by a nurse's aide during a hurried morning round, was 136/84. The note beside it read, "Vitals stable. BP well controlled." The bitter irony was absolute. His daughter, a data analyst like her father, brought me his home logbooks after his death from complications of aspiration pneumonia. 3 years of perfect, serene home readings, a beautiful record of normal physiology, juxtaposed with frantic, escalating clinic numbers and correspondingly escalating prescriptions. She laid them on my desk, her hands trembling not with grief now, but with a spent, hollow anger. "He wasn't killed by high blood pressure," she said, her voice frighteningly calm. "He was killed by the fear of high blood pressure. He was treated for a number that only existed in one room, on one machine, for 10 minutes a few times a year. They drugged him. They chemically altered his entire circulatory system to fix a problem that wasn't there in his actual life. And they drugged him so much that he fell and his brain bled. They treated the room, Dr. Whitman. They treated the anxiety of the clinic. They did not treat my father. When I saw those 2 parallel datasets, The peaceful, consistent home numbers and the chaotic, reactive clinic spikes, I felt a profound and familiar rage. This was more than a clinical misunderstanding. It was a systemic failure to listen, to observe, to prioritize the patient's lived experience over the ritual of the measurement. It was a failure of medicine's core duty, and it was completely, unequivocally preventable. Here's the tragic clarifying truth that Harold's doctor missed. Harold didn't have resistant or severe hypertension. He had a profound, classic case of what we call white coat effect. But his doctor, like so many, conflated it with white coat hypertension, and the aggressive treatment for that misdiagnosis is precisely what engineered his physical decline. He was never offered, nor was he ever administered, the simple gold standard test that could have told the difference between the two. His life was traded for a lack of diagnostic curiosity. If you've ever felt your heart begin to pound the moment the nylon cuff touches your arm, if you've ever held your breath without meaning to as the machine whirs, if you've ever been told to ignore the readings from your own monitor because it must be wrong, I need you to comment "Clinic Fear" below. You are not alone. You are not crazy. You are not a difficult patient. You are experiencing a real, measurable, and often misinterpreted biological phenomenon. And I am reading every single one. So what is really happening in your body the moment you step into that clinic? It is not just anxiety in the emotional dismissive sense. It is a sophisticated, ancient physiological stress response, a fight-or-flight reaction. And for seniors, this response is dramatically amplified, and its consequences are uniquely dangerous. For decades, conventional medicine has brushed this off with a reassuring but ultimately negligent phrase, "Oh, that's just white coat syndrome. Don't worry about it." Or, even worse, "Your home monitor is cheap and inaccurate. Trust our professional equipment." Both statements are dangerously incomplete and, in many cases, factually incorrect. Here's what your doctor likely hasn't explained, either due to time constraints or a lack of updated geriatric-specific knowledge. There are two distinct clinical phenomena hiding under the umbrella term white coat, and confusing them is a critical error. One is benign, the other is a silent predator. First, white coat effect. This is what Harold had. This is a reactive spike in blood pressure that occurs only in the medical setting. In the calm of your home, your pressure is normal. Your body, at a subconscious level, perceives the clinical environment as a threat. The antiseptic smells, the sounds of other patients, the perceived judgment, the loss of autonomy, the anticipation of bad news. This triggers a powerful sympathetic nervous system surge. Adrenaline, epinephrine, and cortisol flood your bloodstream. Your heart rate increases forcefully, your peripheral blood vessels constrict, and your systolic blood pressure, the top number, can soar by 20, 30, even 40 points or more. It's a performance, a physiological act. But when you leave the environment, your nervous system downshifts, and your pressure settles back to its true baseline. This is primarily a nervous system phenomenon, a mismatch between your body's perception and reality. Second, white coat hypertension, WCH, or more accurately, isolated clinic hypertension. This is the hidden danger that often gets missed. Here, your blood pressure is genuinely high in the clinic, but, and this is the critical life-saving distinction, it is also high at home. You just don't know it because you're not measuring it correctly or consistently. The clinic reading isn't a false alarm, it's a louder alarm on top of an already elevated baseline. The white coat moment adds an extra spike onto a foundation that is already unsound. This condition carries a significantly increased long-term risk of true cardiovascular events, like heart attack, stroke, and kidney damage. It's not the coat that's the problem. The white coat is simply revealing a problem that exists everywhere, all the time. The danger lies in assuming it's only the coat. The catastrophe, the Herald-level tragedy, occurs when a well-meaning doctor mistakes the second condition for the first, or more commonly, aggressively treats the first as if it is a sustained, dangerous hypertension requiring lifelong multi-drug therapy. For a senior, the treatment, those potent antihypertensive medications, chase a phantom high number and in doing so drag your real, out-of-office pressure down into the danger zone of hypotension. This is where the real damage begins. Dizziness, syncope, fainting, falls, fractures, poor perfusion to the kidneys and brain, and a catastrophic decline in functional independence. We are not treating disease, we are creating iatrogenic disability. Why are seniors uniquely and exquisitely vulnerable to this misdiagnosis and its terrible consequences? The reasons are rooted in the fundamental physiology of aging. Arterial stiffness. With age, your arteries lose elasticity. They become less like rubber bands and more like stiff plastic pipes. A nervous system surge, a burst of adrenaline, causes a much sharper, higher spike in systolic pressure because the stiff pipes cannot expand to absorb the force of the heart's ejection. A 20-point spike in a 50-year-old with compliant arteries might translate to a 35 or 40-point spike in a 75-year-old with arteriosclerosis. The reaction is mechanically amplified. Baroreceptor blunting. Your body has natural thermostats for blood pressure, called baroreceptors located in your carotid arteries in the neck and your aortic arch. They sense pressure changes and signal your heart and blood vessels to adjust. With age, these receptors become less sensitive. They're like old, worn-out springs. So, after a clinic-induced spike, it takes longer for your body's feedback loop to calm things down. The high reading persists throughout the entire appointment, making it look like a sustained state rather than a temporary reaction. Altered pharmacokinetics. The very medications prescribed to lower blood pressure are metabolized and cleared differently in the senior body. Kidney function, glomerular filtration rate, naturally declines, often silently. Liver metabolism slows. A dose of a drug that brings a dramatic clinic spike down to a normal 130/80ths in the office can cause profound, prolonged lows at home for the other 23 hours of the day. The medication's effect is longer and deeper than intended because the body's clearance system is less efficient. The authority gradient and context. The psychological power dynamic in a doctor's office is heightened for many seniors, particularly those from a generation taught unwavering respect for authority figures. It's not merely nerves. It's a deep-seated, often unconscious stress response to being evaluated, tested, and judged by an expert. You are, in a very real sense, trying to pass. This psychological stress has direct, measurable physiological correlates: elevated cortisol, increased vascular resistance that create the perfect storm for a misleading number. The research that is finally changing the conversation is overwhelmingly focused on out-of-office blood pressure monitoring. A landmark 2023 meta-analysis published in the journal Hypertension reviewed decades of data and concluded unequivocally that for adults over 65, home blood pressure readings are superior to clinic readings in predicting real-world cardiovascular events, heart attacks, strokes, and all-cause mortality. The clinic reading, the one we've based a century of treatment on, was almost irrelevant when compared to the predictive power of home data. Another pivotal study out of Italy showed that up to 30% of seniors diagnosed with hypertension based solely on clinic readings would be misclassified if proper home or ambulatory monitoring was used. We are On a massive scale, overdiagnosing and overtreating. And in geriatrics, overtreatment is not a minor side effect. It is a primary cause of morbidity. But here's what most time-pressed clinicians miss in the whirlwind of a 15-minute visit. They take a single, or perhaps two, stressed readings in a chaotic, unfamiliar environment and, based on that, initiate or intensify a lifelong, life-altering pharmacological treatment plan. They are making monumental decisions with the worst possible, most artifact-ridden data point available. It is the equivalent of deciding a nation's economic policy based on the stock market's activity during a 5-minute panic sell-off. Now, we are at a crucial checkpoint. I need you to engage. This is the most important symptom trail, the connection between mind and body. In the comments below, I want you to type your age and describe in your own words what you physically feel in your body the moment the cuff inflates. Be specific. Age 72. My heart starts racing like a bird is trapped in my chest. Age 80. I unconsciously hold my breath and my shoulders tense up to my ears. Age 69. I get a sinking feeling in my stomach and my palms get clammy. This physical self-awareness is your first and most powerful diagnostic clue. I read every single one. You're now asking the vital question, which one do I have, Dr. Whitman? The harmless effect or the dangerous hypertension? This is the million-dollar question, and the answer lies not within the walls of the clinic, but in the environment of your daily life. The diagnosis is not in their machine. It is in the data you collect yourself. I will give you the clear diagnostic framework, but first, we must collectively destroy the ingrained myth that the clinic is the gold standard for blood pressure assessment in seniors. The evidence has moved on. Let's look at the studies that prove it. Study number 1. The Sprint Mind Trial Sub-Analysis. The original Sprint trial was a monumental study that used clinic readings to guide intensive versus standard blood pressure control, but a later clever analysis looked at the subgroup of participants who also performed home blood pressure monitoring. They found that the home readings were a far more accurate predictor of cognitive decline and silent cerebrovascular disease, tiny silent strokes seen on MRI, than the clinic readings were. Your brain's health is determined by the pressure it is bathed in 99% of the time, while you're reading, sleeping, not the pressure it experiences during 10 minutes of annual stress in a clinical setting. Study number 2. A large Japanese cohort study published in Circulation followed thousands of elderly patients for over a decade, meticulously comparing clinic and home readings. The results were illuminating. They found that those with pure white coat effect, high clinic, consistently normal home, had no increased cardiovascular risk compared to people with normal pressure everywhere. Their prognosis was excellent. However, the study also identified a group with masked hypertension, normal clinic, consistently high home. This group had the highest risk of heart attack and stroke of all, even higher than those with high readings in both settings. This proves the clinic can be not just misleading, but dangerously blind to the most lethal condition of all. Study number 3. The current official guidelines from the American Heart Association and the American College of Cardiology explicitly state that out-of-office blood pressure monitoring, home or ambulatory, is essential for confirming a diagnosis of hypertension. It's right there in the guidelines. It is not an optional add-on, it is a required part of the diagnostic process. But in the rushed, resource-constrained reality of modern primary care, this step is consistently skipped. The clinic reading becomes the default, legally charted truth, and treatment flows from it. The guideline exists, but the practice has not caught up. I am still not giving you a simple one-size-fits-all answer, because you must become the primary data collector in your own health story. You are the only one who can gather the evidence that will set you free from this diagnostic trap. Let me illustrate this with 3 anonymized real patient profiles from my own practice, each with a high clinic number but a radically different truth. Patient number 1, Marge, age 82. Her clinic BP is always alarming, averaging around 170/88. She describes a visceral panic the moment she walks through the clinic doors. Her home readings, however, taken with a proper device after sitting quietly for 5 minutes, are consistently serene: 128/76, 126/74. She has classic white coat effect. Treatment, reassurance, and deprescribing. We worked on slowly reducing her unnecessary medication. Her cardiovascular risk is essentially that of a normotensive person. Patient number 2, Phil, age 79. His clinic BP is borderline, around 145/86. He's a stoic, relaxed man in appointments. His home readings, however, are a different story. He checks sporadically, sometimes after his morning coffee, sometimes while watching the evening news. They are consistently elevated: 155/92, 148/90, 160/94. He has masked hypertension. This is a silent, ticking emergency. The clinic is lulling him into a false sense of security. Treatment: careful, gentle initiation of medication based on the home data with a goal of gradually lowering his true all-day pressure. His risk is very high and was being completely missed. Patient number 3, Ruth, age 85. Her clinic BP is high at 162/90. Her home readings taken with metronomic diligence are also high: 158/88, 155/86. She has sustained hypertension. The clinic reading, while perhaps amplified by a few points, is essentially correct. Treatment: medication titration, but the doses are carefully calibrated using her home values as the guide to avoid overtreatment and dangerous lows. Her risk is high and requires management, but management guided by the right data. See the profound difference? 3 seniors, all with high clinic numbers, 3 completely different underlying realities, 3 entirely different treatment paths. Only by collecting the parallel, contextual data can you and your doctor know which story is yours. Here is the practical framework I use with every single patient to understand where they fall. You can use this to categorize your own situation. Category A: pure white coat effect. High clinic, consistently normal home, your properly taken home readings, more on that protocol next, are consistently below 135/85. Action: deprescribing is the goal. You likely need less medication, or possibly none at all. The primary intervention is to prevent the harms of overtreatment. Normal clinic, consistently high home. Your clinic readings are under 140/90, but your proper home readings are consistently over 135/85. Action: treatment initiation is essential. This is the hidden danger that must be addressed calmly and correctly. The clinic is giving false reassurance. Category C: sustained hypertension, high clinic, high home. Both settings show elevated readings. Action: guided, precise treatment. Medication is needed, but the type and dose should be fine-tuned based on your home data to avoid the lows that cause falls. The clinic confirms, but the home guides controlled hypertension. Normal clinic, normal home. Whether on or off medication, both settings are in a safe range. Action: maintenance and monitoring. Continue good habits and periodic checks. Based on this, comment your suspected category below. Format: Suspect Category A, age 71. This is you forming a hypothesis, the first step in the scientific method you will now apply to your own health. Now, I will give you my exact 5-step true pressure diagnostic protocol. This is not just advice. This is the structured, evidence-based process I use in my clinic to cut through the noise and find the signal. This is how you transform from a passive recipient of care into an active collaborative diagnostician. You will present your doctor not with complaints, but with irrefutable evidence. Step 1. The armamentarium: acquiring the right tool. This is foundational. You must have a validated automatic upper arm cuff monitor. Do not use a wrist monitor. They are highly sensitive to position and are notoriously inaccurate. Look for devices that have passed validation protocols from organizations like the Association for the Advancement of Medical Instrumentation, AAMI, or the British Hypertension Society. Brands like Omron, series like the 5 or 7 series, or Microlife are excellent. Critically, you must have the correct cuff size. A cuff that is too small will give falsely high readings, perpetuating the cycle of fear. Measure the circumference of your bare upper arm. A standard cuff fits arms 2-2-3-2 cm. If your arm is larger, you need a large adult cuff. Ask your doctor's office or pharmacist to check your device and your technique once. This legitimizes your tool in the eyes of the medical establishment. Step 2. The data collection protocol, the sacred routine. Data is only valuable if it's collected consistently. For 7 consecutive days, you will follow this ritual. Morning session, within 1 hour of waking, before taking any morning medications, before breakfast, and after emptying your bladder. Sit quietly in a chair with your back supported and feet flat on the floor for a full 5 minutes. Do not talk, watch TV, or look at your phone. Place the cuff on your bare arm at heart level. Take 2 readings exactly 1 minute apart. Record both numbers, the time, and note any symptoms, e.g., felt normal, slightly dizzy. Evening session, before dinner or before bedtime medication. Again, ensure it's not within 30 minutes of caffeine, a large meal, smoking, or exercise. Repeat the same 5-minute quiet sitting, 2 readings ritual. The no list. Do not take readings over clothing. Do not talk during the inflation or measurement. Do not cross your legs. Do not obsessively watch the monitor screen, as this can cause an alerting reaction and spike your pressure. Look away. Breathe slowly and relax. Step 3. The clinic comparison, creating the controlled contrast on the morning of the last day of your 7-day home monitoring. Go to your pharmacy, many have free stations, or your doctor's office if they allow walk-in checks, and have your blood pressure taken by a machine or a person. Do this after you have already taken your morning home reading. This creates a direct, same-day head-to-head comparison. Your private, basal, resting state versus your public, clinically reactive state. Write down this public reading immediately. This single data pair is often the most powerful piece of evidence you can possess. Step 4. The analysis. Discovering your true average. After 7 days, you will have 28 readings, 2 sessions X, 2 readings X, 7 days. Discard the readings from day 1, as they can be artificially high due to the novelty of monitoring. Now, calculate 2 simple averages. First, average all the remaining morning systolic top numbers, then average all the remaining morning diastolic bottom numbers. Do the same for the evening readings. These averages, for example, morning average 128/76, evening average 132/78, are your true living blood pressure. This number, not the single clinic spike, is what your heart, your kidneys, and your delicate cerebral arteries experience almost all the time. This is the number that matters. Step 5. The doctor. Conversation, the scripted, evidence-based reveal. Schedule a dedicated appointment, not a hurried med check. Bring your printed log sheet and your calculated averages clearly circled. Your demeanor is calm, collaborative, and data-focused. Your script, Doctor, thank you for your time. I've been concerned about the significant difference between my clinic readings and how I feel at home. To get to the bottom of it, I followed the American Heart Association's recommended protocol for home blood pressure monitoring for 7 days. Here is my complete log. My average home blood pressure calculated from this data is X over 40. On the same morning I took this average, my reading here in the clinic was, this suggests I may have a significant white coat effect. Given that the guidelines state home readings are more predictive of actual cardiovascular risk for someone my age, can we review my current medication regimen together? I want to ensure we are treating my real blood pressure and avoiding any risk of overtreatment and side effects like dizziness, which I have been experiencing. You are not a difficult patient. You are an engaged partner providing high-quality, guideline-concordant data. You shift the conversation from opinion to evidence. Now, let's preemptively address the most common questions, fears, and pushback you will encounter. Q1. My doctor insists home monitors are inaccurate, and I should only trust the clinic. How do I overcome this? You respond with a combination of respect and evidence. First, ensure your technique is flawless. Step 1. Then say, I understand the concern. I made sure to get an upper arm monitor that is clinically validated. I also followed the AHA's pre-measurement protocol of sitting quietly for 5 minutes, which often isn't possible in a busy clinic. I've brought the raw data. Would you be willing to compare one of my home readings to an in-office reading taken with me relaxed after a full 5-minute rest in the exam room? This invites collaboration. If they still flatly dismiss your data despite your rigor, it may be a sign to seek a second opinion from a physician, perhaps a geriatrician or a cardiologist, who practices modern, evidence-based, patient-centered care. Q2. I get high readings at home sometimes too, especially when I'm upset or in pain. Doesn't that mean I do have true hypertension? Everyone has situational spikes during an argument, after startling news, during acute pain. Hypertension is defined by a sustained elevation of your baseline. The 7-day, twice-daily protocol is designed to smooth out those temporary, emotionally driven spikes and reveal your underlying habitual pressure. If your 7-day average is consistently at or above 135/85, then you meet the diagnostic threshold for hypertension and fall into category C. The goal is to treat that baseline, not the occasional storm. Q3. If I truly have just white coat effect and don't need more medication, what do I actually do about these terrifying high clinic readings? Won't my doctor keep worrying? We manage the reaction itself. Techniques include unobserved, automated readings. Ask the nurse or medical assistant to start the automated machine, leave the room and return when it's finished. The absence of an observer often reduces the spikes significantly. Borrowed time. Politely request to sit alone in the exam room for 5-10 minutes before the reading is taken. Use that time to practice diaphragmatic breathing, desensitization. Visits, schedule brief, blood pressure-only visits where no other exams or discussions happen. The goal is to condition your nervous system to not see the environment as a high-stakes threat. Engage the parasympathetic nervous system, practice the 4-7-8 breathing technique, inhale through nose for 4, hold for 7, exhale through mouth for 8, for 2 minutes before the cuff inflates. This directly counteracts the fight-or-flight response. Q4. What about 24-hour ambulatory blood pressure monitoring? ABPM. Is that better? ABPM is considered the diagnostic gold standard. A small device is worn on a belt with a cuff on your arm that automatically inflates every 20-30 minutes during the day and every hour at night. It provides an unbeatable picture of your diurnal rhythm, including critical nocturnal dips. If your doctor is highly skeptical of your home data, or your case is complex, requesting this is a powerful next step. Say, to definitively resolve the discrepancy and get the most accurate diagnostic picture, could we order a 24-hour ambulatory blood pressure monitor for diagnostic uncertainty? It is often a covered service under insurance. Q5. I'm already on medications, and I feel dizzy and tired all the time. I'm scared to change anything. What do I do? This is a potential medical safety issue. Do not stop your medication abruptly. Begin the 7-day home monitoring protocol immediately. If your home averages reveal consistently low readings, e.g., systolic consistently under 110, or correlate with your symptoms of dizziness, you have strong evidence of overtreatment. Call your doctor's office with this specific data. Say, I completed a 7-day home BP log. My average blood pressure is 106/68, and I am experiencing daily dizziness, especially when standing. I am concerned about being over-medicated and my risk of falls. Can we please discuss a plan for a safe, gradual dose reduction? This frames it as a safety imperative, which it is. Let me leave you not with Harold's tragedy, but with a story of reclamation. Meet Irene. Irene was 80, sharp as a tack, but growing frail. She was on 3 different blood pressure medications. Her clinic readings were always in the 150s/80s, which her doctor interpreted as uncontrolled, prompting discussions of a 4th drug. At home, she was a prisoner of her recliner, afraid to walk to the mailbox because of relentless dizziness. Her home readings, when she dared take them, were in the 90s/50s. She was trapped. She came to me and we executed the 5-step protocol. Her 7-day home average was 98/60 seconds. She presented the crisp log and the sobering average to her primary doctor. Seeing the unambiguous evidence of dangerous over-treatment, her doctor, to his credit, agreed to a carefully supervised deprescribing plan. Over 3 months, we slowly, systematically tapered her off 2 of the 3 medications. Her clinic reading on the single remaining low-dose drug, 144/80 seconds. You know, Irene, her doctor said, we can live with that. Your safety at home is more important. Irene's dizziness vanished within weeks of the first dose reduction. Her energy returned. She started walking again, tentatively at first, then with confidence. At her last visit, she told me, I got my legs back. I got my life back. I was being treated for a ghost. Harold's story is the dire warning of the path we are still on. Irene's story is the illuminated path forward, the proof that change is possible. You have the power to change your script. You now possess a powerful body of knowledge. You understand that the most clinically relevant blood pressure is the one you live with 24 hours a day, not the one you perform under duress. You can distinguish between a nervous system artifact and a true, silent, vascular emergency. You hold a battle-tested, step-by-step protocol to capture the objective truth of your cardiovascular health. And you have the precise, respectful language to change a potentially adversarial conversation into a collaborative one. This information liberates you. It moves you from being a passive subject, a victim of a single flawed data point, to being the author of your own health narrative. The time for action is now. First, order a validated upper arm blood pressure monitor today. Do not put it off. Second, begin the 7-day data collection protocol tomorrow morning. Treat it with the importance of a medical test, because it is. Third, stand in front of a mirror and practice the script. Own your data. Own your story. Before you close this video, I need 3 things from you. This is how we build a movement, a community of informed seniors who advocate for their own best care. Hit that subscribe button and ring the notification bell. This channel is dedicated solely to arming seniors with the nuanced, evidence-based knowledge needed to navigate a complex and often ageist medical system. We go beyond the headlines to deliver practical, life-saving strategies every single week. Share this video strategically and privately. Do not just post it to your public wall. Send it in a private text to your spouse, your siblings, your bridge group, your coffee clutch. Email it to your children so they understand what to advocate for. This misunderstanding is universal, and the consequences are dire. You could literally prevent someone you love from starting a harmful medication cascade, from experiencing a fall, from suffering a fracture that begins a decline. Leave your final, defining comment. Choose one. This tells me what step you're committing to and shows others in the comments they are not alone in this journey. Comment home data if you are committing to the 7-day home monitoring protocol. Comment clinic spike if you now understand your high readings are likely a reactive effect, not true hypertension. Or comment for Harold to honor his memory and to pledge that you will be your own best, most rigorous data advocate, ensuring such a tragedy is not repeated. Thank you for your trust, your attention, and your courage in seeking the truth. Watching this to the end proves you care deeply about your health, your autonomy, and your future. You are not a passive patient. You are an active, essential partner in your care. Remember, the goal of medicine is not to achieve perfect numbers on a clinic chart. It is to preserve your function, your independence, and your quality of life for as long as possible. You hold the key to aligning your care with that true goal. I am Dr. Alan Whitman. Stay strong, stay curious, and never stop advocating for the care you deserve. I'll see you in the next video. Disclaimer: the content in this video is for educational and informational purposes only and is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified health provider with any questions you may have regarding a medical condition. Never disregard professional medical advice or delay in seeking it because of something you have seen in this video. Do not initiate change or stop any medical treatment or medication based on the information presented here. Always consult with your personal physician before making any healthcare decisions. The protocol described is a general framework and must be individualized under professional supervision.